Hello class, my name is McKenna Brown, and today I'm going to be teaching you about the primary care guidance for persons with HIV 2020 updates.
Hello, McKenna. I'm very excited to dive into this topic with you on primary care guidance for persons with HIV, the 2020 updates. This should be very informative and exciting, so I'm ready to get learning.
The objectives of today's presentation are to define the disease state, talk about the diagnostic criteria and diagnostic testing recommended for this disease, the disease management recommendations, the differences from the previous publication of these guidelines, and differences from other organizations' recommendations.
McKenna, thank you for outlining the objectives of this presentation so clearly. I am very excited to learn and touch on all of these different points.
Here you can see the official title of the guidelines, Primary Care Guidance for Persons with Human Immunodeficiency Virus 2020 Update by the HIV Medicine Association of the Infectious Diseases Society of America. You can see that the professional organization that published these guidelines put their name in the title, so that's them right there. You can see the authors listed here. And as for the key to strength of evidence, there was no evidence strength key provided for the 2020 update, nor was strength of evidence listed in each of the recommendations.
Thank you for sharing the details of the practice guidelines, including the authors and the official guideline title. I am excited to see exactly what each of these guidelines states.
The Centers for Disease Control defines human immunodeficiency virus, HIV, as a virus that attacks the human immune system and can lead to acquired immunodeficiency syndrome if not treated. That happens when the CD4 count goes below 200 or there's a development of opportunistic infections. There is no cure to having HIV. It does stay with the infected person for life, but it can be controlled with proper medical care.
McKenna, thank you for so clearly defining HIV and AIDS for us, as I do often forget exactly what the CD4 count is for those with this disease. However, it is amazing to know that this is actually a pretty common disease in the US. 1.2 million people approximately in the US have HIV, and that's of 2023 from HIV.gov.
You can see here the author's stated purpose of the guidelines, as there is an ever-increasing number of people living with HIV and requiring HIV-specific primary care. There is a need for an updated recommendation for the 2013 HIV primary care guidelines. The authors also stated that ending the HIV epidemic has proven to be challenging. They state that only 59.8% of those that are aware of their HIV diagnosis are actually achieving viral suppression, and there are even lower rates among African Americans, Hispanic, Latinos, transgender women, persons aged 13 to 24 years, persons who inject drugs, and those living in the South. Identifying and overcoming barriers to care and engaging our patients in continuing their antiretroviral therapy is an overarching priority of HIV primary care, according to these authors, and that is another reason they wanted to publish these updated guidelines to ensure stigma-free, culturally appropriate, and patient-centered care at the forefront of the treatment for these patients. Finally, the authors state that another reason for the publication of these updated guidelines is that while antiretroviral therapy has become more potent and less toxic, there are simpler aspects of HIV care that are becoming more complex due to people with HIV living longer.
McKenna, it is so awesome that today we are able to help individuals diagnosed with HIV through antiretroviral therapy. That was not always the case, and I think we will continue to learn more about treatment of this disease. I also agree that it is important to provide patients with HIV diagnosis a stigma-free, culturally appropriate, patient-centered care environment, especially when it comes to stigmas around individuals who have HIV. It can be important that these patients feel comfortable seeking care when it comes to their diagnosis. I also find it very interesting that you found differences, or resources that found differences in how patients are respond, or really how they are able to meet the goals of their treatment based on ethnic background, sexuality, and also you said those in the South as well. I find that very interesting and would like to find out more about that. I am wondering why those of different ethnic backgrounds, specifically different sexualities, and based upon location, why they are having more difficulty meeting the goals of their HIV treatment.
You can see here the diagnostic criteria for this disease state is through HIV antibody antigen testing. This will confirm the presence of the infection or not, and it's needed for the diagnosis. And these clinical guidelines recommend that patients who do not have documentation of their HIV status or who were tested anonymously should have this tested upon initiation of care.
McKenna, thank you for sharing the diagnostic criteria for HIV and the HIV antibody antigen testing. I also believe that HIV screening is important using this testing because according to HIV.gov, of the 1.2 million people in the US that have HIV, approximately 13% of them don't know that they have it and they need testing. Therefore, this test can be very important in screening as well.
More recommended testing according to these guidelines is to get a CD4 cell count with percentage at the initiation of care. This will help to stage the infection and to establish if there's a risk for the HIV-associated complications such as opportunistic infection, prophylactic agents needed to be initiated or not. The plasma HIV RNA polymerase chain reaction, HIV viral load, will help establish baseline and monitor viral suppression. And HIV drug resistance testing should be completed as well for those who have never initiated therapy, those who are restarting therapy with no care currently, or those who are restarting therapy with inconsistent care in the past.
McKenna, I believe that these tests are also important when the patient has a diagnosis of HIV, so we are able to properly treat that patient for the appropriate stage of HIV that they are currently in, and we are able to provide the best overall care for that patient and adopt a good regimen for them.
Now let's discuss management recommendations. There are 96 total recommendations throughout this clinical guideline publication, and they are split up into 9 sections. Our first section is optimizing care engagement, medication adherence, and viral suppression, and those are the guidelines 1 through 4. The authors state that all persons with HIV need to be provided with timely access to routine and urgent medical care. This will include approaches such as extending hours or telehealth and providing more access to care to patients. HIV sites also should make efforts to be language and culturally appropriate for their patients. Evidence-based intervention and care is recommended. Programs that incorporate evidence-based interventions that are shown to improve HIV care engagement and viral suppression. HIV care sites should also use a multidisciplinary model with a primary care clinician that is there to develop the trusting long-term patient-clinician relationship. The next section is initial evaluation and immediate follow-up for persons with HIV, which covers guideline recommendations 5 through 45. So this is an extensive section that discusses a comprehensive HIV-related history should be obtained from the patient at the initiation of care. This is including everything that normally occurs but is HIV-specific: past medical history, review of systems, physical examination, doing a complete care visit at the initiation of care. Furthermore, the guidelines state that many patients are not going to be able to recall their details of the prior treatments, so medical records should be requested. Testing for all patients, as discussed in the previous diagnostic slides, is covered in this section. There are also many recommendations for testing in selected patients, such as when you're considering certain drug classes. They discuss what testing should occur with that, and they also recommend just the baseline labs of CBC with differential CMP, estimated glomerular filtration rate or creatinine clearance, glucose, and urinalysis at initiation of care.
McKenna, I agree with these guidelines and the importance of them. When a patient is diagnosed with a chronic condition such as HIV, it is very important for them to receive timely, routine, and urgent medical care. This is something they're going to have to be following up with somebody with for probably the remainder of their life. So it's important that we take language and cultural considerations into account and that they build that trusting relationship with their provider when it comes to managing their disease. I agree that it is most important to be sure that we are obtaining an accurate HIV-related history. We may need to gain records in order to be able to do this accurately. It's important to do the appropriate testing when it comes to consideration of certain drugs and to obtain baseline labs.
Furthermore, the guidelines outline STD testing that should be occurring at the initiation of treatment, screening for gonorrhea, chlamydia, syphilis at all sites of contact. They also recommend that all persons who are having vaginal sex should be screened for trichomoniasis at entry to care as well. All patients should be screened for syphilis at the beginning of care. Furthermore, at the beginning of care, persons with HIV without a history of tuberculosis or prior positive screening test should be screened for Mycobacterium tuberculosis. For hepatitis, they recommend HBV screening for immunity to hepatitis A, HCV antibody screening, and to immunize as necessary. All persons with HIV born in 1957 or after should be tested for immunity to measles, mumps, and rubella by measuring antibodies, and the vaccine should be given if persons were born before 1957 or after and they have not received the vaccine or do not have immunity to these infections already. Cervical cancer screening should happen if not done within the last year. Routine HPV testing isn't recommended for women with HIVs aged less than 30 years old unless the Pap test is abnormal. For anal cancer screening, they recommend with an abnormal cervical test Pap results, and persons with genital warts should have screening for this. Screening for the glucose 6-phosphate dehydrogenase deficiency is recommended before starting therapy with an oxidant drug such as dapsone. In patients that have the predisposing ethnic or racial backgrounds, such as those with African, Mediterranean, or Asian descent. They recommend a pregnancy test at the initiation of care. Serum testosterone, morning testosterone levels are recommended in the adult cisgender men that have decreased libido, erectile dysfunction, bone mass, or low trauma fractures, hot flashes, or sweats. Serum testosterone testing isn't recommended in women. And finally, this section covers tests that are not recommended for general screening, such as HSV, CMV, toxoplasma, and inflammation markers. The next section talks about routine healthcare maintenance considerations for persons with HIV. This covers guideline points 47 through 76. For HIV RNA monitoring, they recommend 2 to 4 weeks after the initiation of antiretroviral therapy, but no later than 8 weeks, and then every 4 to 8 weeks until the suppression is achieved. After that, then they recommend viral load monitoring every 3 to 4 months to confirm maintenance of suppression below stable. For CD4, they recommend every 3 to 4 months for prophylactic need assessment. So if the CD4 count is less than 200, understanding that they may need prophylactic antibiotics for the opportunistic infections. Substance abuse screening should occur at all healthcare encounters, and depression screening should be done using a validated tool at least annually as well as needed. Vaccination for infectious diseases, screening for syphilis, chlamydia, and gonorrhea in asymptomatic individuals with HIV should be done after the initial screening annually or at least every 3 to 6 months, depending on the patient's sexual activities, presence of other STIs, or local community STI prevalence. And they also recommend that all persons who have vaginal sex should be screened for trichomonas annually, as stated previously. Vaccinations for pneumococcal infection, influenza, Tdap, meningococcus, they should be offered according to the CDC opportunistic infection guidelines. Asymptomatic individuals with a CD4 count of greater than 200 who are traveling internationally, they should receive the required vaccinations, including the live vaccines. For hepatitis A and B, vaccination should be recommended for non-immune sexual partners of our patients who are positive for hepatitis B antigen. Patients who are negative for the antigen and are positive for the antibody should receive vaccination. For HPV, those that are between 27 and 45 years of age who were not vaccinated before should be offered this as well. Those who have not been vaccinated or don't have exposure to the varicella virus should receive post-exposure prophylaxis. Varicella primary vaccination could be considered in persons with CD4 cell counts that are greater than 200 and in children with HIV that are 1 to 8 years old with a CD4 percentage of greater than 15. As for cancer screenings, all patients who are smoking should be strongly encouraged to stop. Screening for smoking needs to be done at every healthcare encounter. Breast, prostate, lung, and colon cancer should refer to the USPSTF and the American Cancer Society guidelines for just the general population.
I do agree with these guidelines that it is extremely important to be screening these patients at initial evaluation and immediate follow-up. It is important to screen patients for infections because they are at an increased risk of infection, opportunistic infections, because they have a damaged immune system. It's important to do STD screening, screen for latent TB, etc., and to screen for cancers that they may be at risk for as well. I heard you talk about vaccines and how it can be important to at times give the live attenuated vaccines to these individuals. I did some research, and according to the National Institute of Health, live viral vaccines, including the MMR, varicella, and zoster, can be considered for at-risk HIV patients who are clinically stable and have low levels of immunosuppression, which they equate to a CD4 count greater than or equal to 200. So these patients may receive the live attenuated vaccine.
The next section covers recommendations 77 through 80 through the metabolic and other non-communicable comorbidities associated with HIV, antiretroviral therapy, and aging. In this section, they discuss lipid levels and how they should be drawn prior to and within the 1 to 3 months after starting the antiretroviral therapy. Patients that have abnormal lipid levels should be managed according to the National Lipid Association and the 2018 multi-specialty blood cholesterol guidelines. They recommend that a random or fasting blood glucose and the hemoglobin A1C should be obtained before starting antiretroviral therapy, and if it's abnormal, the fasting glucose should be obtained. After beginning ART, only plasma glucose criteria should be used to diagnose patients with diabetes, and they should have an hemoglobin A1C monitored every 6 months with a goal of less than 7 in accordance with the American Diabetes Association. So nothing different there. For the baseline bone density scanning, the DEXA scan screening for osteoporosis, it is recommended by the society to be performed in postmenopausal women and men aged greater than 50 years old. And for the testosterone replacement therapy, they recommend that cisgender men should be prescribed with caution and only those with symptomatic hypogonadism given the long-term side effects of this. The next section covers special considerations for cisgender women and transgender men of childbearing potential and for the prevention of perinatal HIV transmission. So that is guidelines 81 through 84. They discuss contraception and pre-contraception care. They recommend that providers ask patients about their potential childbearing plans and desires and have an open discussion about that with them. And they also should ensure that the informed decisions are made about contraception to prevent unintended pregnancy with a patient with HIV. They also discuss guidelines for prevention of perinatal transmission. To prevent perinatal transmission, all pregnant persons with HIV should be treated with antiretroviral therapy, regardless of their immunologic or virologic status. They recommend that therapy is initiated as early as possible, even prior to conception. So if they are planning this, that is a discussion that should be had with the provider. And then they recommend that infants exposed to HIV in utero should be managed according to the DHHS perinatal guidelines. For breastfeeding in the United States, persons with HIV should avoid breastfeeding. The next section, they discuss special considerations for children. This is guidelines 85 through 89. So infants that are diagnosed with HIV should undergo the HIV resistance testing prior to administering the drug, so they can discuss which drugs the patient may be resistant to. All children with HIV should initiate ART regardless of their CD4 cell count, and CD4 cell counts should be monitored no less than every 3 to 4 months with children. Childhood vaccinations should be administered according to the Advisory Committee on Immunization practice schedules for infants and children with HIV. Finally, they discuss how infants and children with HIV should be managed by specialists. This is a special population, and these specialists will have knowledge of therapeutic and pharmacologic, behavioral, psychosocial, and development issues associated with HIV in the children population. Finally, the next section, 90 through 92, is special considerations for adolescents. So adolescents with HIV required most definitely developmental approaches to therapy. With this age group, everything is developmental, and that's no difference. It only becomes more complicated when HIV is in the picture. So they should most definitely have coordinated and deliberate care when transitioning from the adolescent to the adult world. Coordination should occur between the adolescent / pediatric provider to the adult provider. Finally, they discuss recommendations for vaccines for this population just to administer according to the Advisory Committee on Immunization practice schedules for children with HIV.
Thank you for all of this knowledge. I agree that children with HIV and adolescents with HIV should be seen by a specialist who specializes in HIV treatment for this special population group, we often don't think about these individuals being diagnosed with HIV. However, it does happen, so we are able to direct them to these appropriate specialists to get them the best quality care that they need to manage their disease.
So finally, the last two sections, the considerations for transgender and gender diverse populations aged at least 18 years old. This is points 93 through 96. So this section discusses providing gender-affirming, non-discriminatory, non-stigmatizing, and culturally sensitive care. So this includes things like intake forms, medical records, and documentation, providing these patients with gender-neutral terminology and gender identity options rather than just what is limited to what they were given at birth. They recommend that transgender individuals with HIV should be offered medical and surgical therapy to provide gender affirming care. And for the cancer screenings, they should be conducted based off of guidelines for the organs and tissues that were present in the individual currently. Finally, they have one last section. They don't number that as technical guidelines or the recommendations, but they do add a section on considerations for the severe acute respiratory syndrome coronavirus 2 pandemic and coronavirus disease 2019 in persons with HIV. And essentially, they just say for the latest information, consult the guidelines from the IDSA for recommendations on testing, treatment, and prevention of COVID. Use the DHHS guidelines regarding the antiretroviral therapy.
Yes, I'd agree. It is very important to ensure that these individuals receive gender affirming, non discriminatory, non stigmatizing, culturally sensitive care so they feel comfortable while they are receiving the care for their diagnosis. When it comes to cancer screenings, this is an area that really interests me with my oncology background. According to the Johns Hopkins Medicine website, people with HIV or AIDS are more likely to develop cancers of the skin, anus, lung, and liver, as well as develop Hodgkin's lymphoma. Therefore, it is important to do cancer screenings on these individuals.
So, the previous version that was published was the Primary Care Guidelines for the Management of Persons Infected with HIV 2013 update by the HIV Medicine Association of the Infectious Disease Society of America. So, one of the biggest differences is that in 2013 they had a grading system for the guidelines. There is not a grading system for the guidelines in the 2020 recommendations. The 2020 guidelines go into detail about history taking recommendations and discuss exactly what aspects of the history should be discussed in terms of review of systems, patient history, family history, medication history, and they go into much greater detail than the previous guidelines did and provide primary care providers with exactly what they should touch with their patients during this section. The 2013 guidelines also have behavioral recommendations about risk reduction and discussing about risk behaviors with patients and referring out if the patient needs to. And then finally the 2022 or the 2020 update discusses the COVID-19 update and who to refer to for that.
I believe that the additions of the detailed history taking recommendations and behavioral recommendations in the COVID 19 update are very important features of the new guidelines, especially the behavioral recommendations. It's important to properly educate our patients on at risk behaviors when it comes to management of this disease.
As far as difference from another professional organization, the New York State Department of Health AIDS Institute Comprehensive Primary Care for Adults with HIV are the 2022 guidelines that organization published. They These guidelines discuss care for those that are greater than or equal to 18 years of age. This section also develops a trauma-informed care approach, discussing how to provide trauma-informed care to our patients. The guidelines that were discussed in this presentation talk about asking patients about any trauma in their history, but they don't necessarily discuss trauma-informed care as an approach. And finally, this section or this form of guidelines from the different professional organization discusses prophylaxis treatment recommendations for the opportunistic infections and exactly what would be prescribed.
I agree that it is important to maybe address trauma, and trauma informed care can be a benefit to some of these patients. I also agree that prophylaxis for opportunistic infections is very important when it comes to immunocompromised individuals.
Finally, as future primary care providers, we are inevitably going to come into contact with persons of this population, and it's important that we understand up to date recommendations and guidelines on how to properly provide the best evidence based care for this patient. I hope you found this presentation informative and that we will all understand how to take care of these patients in the future.
McKenna, thank you so much for your very well detailed, informative presentation. I learned a lot, and I was happy to hear about the 2020 guidelines when it comes to managing these patients. I am very excited for what the future holds for us as future nurse practitioners, and I know this is part of the population we will come in contact with, so thank you for this review. Your references are very clear and concise in the correct APA format. Thank you for sharing all of this information with me once again. I learned a lot.